Respected judges, teachers, and all my dear friends, a very warm good afternoon to one and all. Today I'll be standing here to present a case series of Micropulse transcleral diode laser cyclophotocoagulation in patients with iridocorneal endothelial syndrome. As you all know, ICE syndrome is characterized by the abnormal proliferation of the corneal endothelium, and it's characterized by corneal edema, iris atrophy, and secondary angle closure glaucoma. And the glaucoma is often refractory, requiring multiple surgical interventions. And medical therapy is usually unsuccessful in more than 50% of the cases. And also the managing long-term success even with augmented trabeculectomy or glaucoma drainage device is also pending. So we opted for a ciliary body destruction procedure. We have the continuous way with so many side effects, and hence we opted for the Micropulse, which was a new kit at the town, with which was explained to have less side effects. And also when we looked in the literature, there were no studies exclusively for Micropulse done in ICE syndromes, and hence we opted for Micropulse in our ICE patients. And our aim was to evaluate the efficacy and safety of Micropulse in patients with iridocorneal endothelial syndrome and to understand their clinical profile. It was a retrospective analysis of a consecutive case series. The medical records of 3 IC patients were analyzed, and the epidemiological factors and the number of anti-glaucoma medications pre and post laser and the detailed glaucoma evaluation findings were recorded. The first case was a 36-year-old female with best corrected visual acuity of 6/18, a progressive iris atrophy with a 0.9 cup with intraocular pressure of 46 on 3 anti-glaucoma medications. In the second case was a 47-year-old female with progressive iris atrophy, a best corrected visual acuity of 6/12, and a 0.9 cup with intraocular pressure of 22 on 4 anti-glaucoma medications. And the third patient was a 39-year-old female with Chandler's syndrome with best corrected visual acuity of 3/60, 0.9 cup, and the intraocular pressure was 42 on 3 anti-glaucoma medications. And the cyclo glaucoma iridex machine was used in its Micropulse treatment mode at a power of 2000 milliwatt power with the 80 seconds per hemisphere, and the duty cycle was 31.3. It was given in the sweeping motion, the superior and the inferior quadrant, avoiding the 3 o'clock and the 9 o'clock areas. And all the patients post-laser received topical prednisolone, the atropine, estesolamide 500 milligram for 3 days, systemic analgesics, and I was advised to continue the previous anti-glaucoma medications. And the follow-up was done at 1 week, first, second, third, and 6th month. The significant visual impairment, more than 2 lines loss, hypertonia, and thighs were considered as major complications. Anterior segment inflammation and transient visual acuity deterioration were considered as minor complications. And the post-operative, the best corrected visual acuity, slit lamp evaluation findings, and intraocular pressure were recorded. And intraocular pressure of 6 to 21 millimeter mercury or reduction of IOP by 20% at 6 months were considered as treatment success. The inability to meet the criteria, the above criteria, or the need of retreatment more than 3 times, or the need of an incision glaucoma surgery were considered as treatment failure. The results, all of the cases were unilateral. It was the middle-aged women which were the ones affected. And the progressive iris atrophy patients present with defective vision and pain was associated with Chandler's syndrome. And all the 3 patients, the other eye showed narrow angles for which the laser iridotomy was done. Hence, we should not forget to see the other eye of these patients. And all the 3 patients also had advanced glaucomatous changes in the affected eye at the time of presentation. The mean pre-laser IOP was 40 plus or minus 15.87 millimeter mercury. At 1 week, we had a 67.5% reduction of intraocular pressure. But by 3 months, IOP again spiked back to 34, and it remained high at 6 months also. The number of anti-glaucoma medications actually was adjusted at 1 month follow-up, but again, about at 3 months again, it came back to the previous anti-glaucoma medications. We could see that the IOP dip was there at 1 week, and it was maintained for about 1 month, but after 1 month again, the IOP spiked back. There were no major complications. There were mild transient post-operative inflammation was there in all the 3 cases, with the 1-line vision loss was seen in 1 patient. 1 patient was retreated at 3 months, but the IOP remained high after the repeat treatment after 2 months. And the discussion, actually we could not see studies where Micropulse was given exclusively in ICE syndromes, and hence this was the first case series which was done. But we could see several studies of Micropulse in refractory glaucoma And in a study conducted by EMMATTY et al., even though they showed a reduction of 53%, there was no standardized protocol used in that study, and the mean duration also was more in that study. In a study conducted by Suisi et al., it was also done in refractory glaucoma. The pre-laser IOP was lesser than compared with us, and they had a 35% reduction was seen at 6 months and also at 1 year. In the study conducted by Preda et al., the 41% reduction was maintained at 6, 12, and 18 months, but the number of retreatments were more in this study. The limitations were we could not proceed with micropulse in these eyes patients due to the poor response of these patients, and hence the number was less. So the conclusion is always look the other eye in these eyes patients to rule out for angle closure. And micropulse per se is not a definitive treatment of refractory glaucoma secondary to eyes, or it may help in decreasing the medication burden meanwhile preparing for the definitive incision surgery. These are my references. Thank you.